Hey, everybody. It's a great pleasure to be the moderator of this table. And in this critical lung day, this has been it's going to be a great session. 3 sessions we're going to have, and we are going to refer to very relevant topics with a very important scientific research. And I believe they're going to be very interesting and enriching for everybody. We're going to have 3 topics, and they try to approach globally the treatment of these patients with mechanic ventilation. The first speaker is Margarita Marquez from the Hospital of Toledo. She's going to speak about a chronic critical patient, and every day this is being more relevant. There's very little published evidence, and it's very important to speak about this. And then Dr. Federico Gordo from Koslava, he's going to speak about orotracheal intubation. There has been a lot of advancements in this area and different published articles and trials. And he's going to review this information. And finally, Dr. Jordi Rivera from Valdeprona, Barcelona. He is a very relevant doctor in patients in ECMO treatment. He's going to speak about the latest advancements in this area. Now, at the end of the 3 sessions, we're going to have a Q&A. And okay, now Dr. Margarita Marquez with the first session. Sorry, there's too much echo. Give me a second. Sorry.
Vale, creo que no sé si me oís ahora porque estamos teniendo problemas con el audio. ¿Alguien me puede...? Porque estáis viéndome también a través de aquí. Vale. Perdón. Bueno, buenas tardes a todos. Gracias por contar conmigo para participar.
For participating. I'm Dr. Margarita Marquez. I'm an intensivist, and I have worked in chronic critical care of this hospital. I have no disclosures, and this is the agenda of my talk for today. Let's start directly with chronic critical illness. And why are we speaking about this topic today? We know that the main features of this patient is because of a longer stay, more than 15 days, dependent of mechanic ventilation. They have survived to the initial event, but they haven't been able to recover. And we have seen that there's more risk of chronicity of elderly patients and those with comorbidity. Clinically, these are the features. It's an inflammation, immunosuppressive, and persistent catabolism syndrome. And we know they have a lot of alterations of the neurological system, skin, muscle system, and there's a lot of stress. There's a lack of communication, and because there's tracheostomy, they have high mortality, 31%, and the mortality up to 3 years, 75%. We believe that these kind of patients are going to increase because, we have more elderly patients. They survive more to the acute events. Next slide. There we go. And tracheostomy early. Tracheostomy is beneficial because it decreases the pneumonias, like we can see here, and the stay at the ICU can be shorter, as we see on the graph. There's also decrease in mortality. During the COVID pandemic, the use of early tracheostomy was used as a resource to treat these kind of patients. There was a shortage of beds. So we needed to have early weaning from the ventilator. Patients that have tracheostomy, they need special cares, at least intermediate care, because these kind of patients have to be really take care of so we don't increase mortality. Chronic critical patients that we are going to speak of, it is necessary to create specific units for these kind of patients because, of course, we're trying to do the weaning, but there are other issues that we have to face and that they require a multidisciplinary approach: nutrition, physical therapy, psychological therapy, etc. We need more open units and more family contact. Now, speaking about the respiratory issues, let's speak about the airway handling. These patients are going to be weaned off and they're going to have spontaneous respiration. Every time is going to be longer. Here, how we're going to be successful? Well, we need a fenestrated cannula and a 7 millimeter inner diameter. And this will make an easier weaning, less infections, and less ICU stay, and improvement in dysphagia. Now, speaking about the weaning, these are the French guidelines. Even though we should consider have a smaller cannula and allow that the patient will breathe better when they are spontaneously breathing. Also, a deflated cuff helps. Now, speaking about the weaning, the effect of pressure support versus unassisted breathing through a tracheostomy collar. We see the weaning duration median in all patients and the duration of spontaneous breathing. This is influenced, like it says in the guideline, in a humidified airway. The warm air is related with a decrease of needed aspirations, mostly after the 14th day, and there's an improvement in the ciliary and mucus function of the airway. How are we going to achieve this heating and moisture through the tracheostomy? With a high flow oxygen, we can achieve this through the tracheal pathway. Even though there are no changes in CO2, we've seen improvement in the aspiration of the trachea. And Here we see the high flow therapy in tracheostomized patient at high risk weaning. So after 50 liters through the tracheo, it can benefit the conditioning of the airway so it keeps the moisture and the temperature. Now, speaking about the patients that have been already weaned, I wanted to mention this consensus because it's important, even though it's a little bit older. The decannulation process is going to be similar. I'm going to speak later in detail about this. So now we don't need an occlusion. In the guidelines, we see the guidelines from the French panel also speaking about the pharyngolaryngeal examination. It should be done always. Of course, this increases the costs and it won't be necessary in all the patients. Now, speaking about the capping, we see a delay in decannulation of patients compared to other variables. For example, the need for aspiration in the tracheostomy. When the patient has less than 2 aspirations per shift, they can be ready for decannulation without the need of capping. In this study, there's a previous maneuver and they turn off the cannula and we tell the patient to swallow and cough. So sometimes we don't need an endoscopic study in all of the patient. So we can do a capping for a very short time and do a short test. So we don't always need the endoscopic study. So I would like to highlight these articles. There are benefits in the cognitive level, mostly during the stay because it decreases and we have seen that it doesn't decrease the times and it has some adverse effects. And we see in this study, there are no effects that are beneficial of the staying days or immortality, but we see important adverse effects that were in these patients where we mobilized early.
Also, early mobilization during this study is very aggressive, and fatigue was produced in those patients. Of course, what is clear is that management in chronic critical care ICU has to be multimodal. It has to include all different spheres of the patient, psychosocial, mental health, rehabilitation, cognitive rehabilitation, motor rehabilitation, education for to be able to swallow, to speak, and that we shouldn't focus only on motor rehabilitation process in itself. I also wanted to mention the role of coughing assistance. These are starting to be used, and we have seen that they can improve capacity to cough or to clean secretions, reducing time hospital stay. So that this would be the graph of normal coughing where we see a peak. This is peak exhalation over 360 liters per minute. And the use of this type of device is recommendable when it's under 180. And why is this? Because we already saw that under 160 patients had a higher risk of intubation when the cause of reintubation was the wrong management of secretions. And going now to the last part of my talk in terms of delirium and brain dysfunction, I wanted to mention the package of ABCDF measures, the bundle that reduces time, ventilation time, the time of sedation. It also reduces delirium. It increases pain, but it's perhaps because patients are more awake and they are more aware of pain. So it's interesting to learn about this bundle of measures and implement it in the ICU. And to finish my conclusions, as I was saying, there will be an increase and chronically critical ill patients are increasing. There's an increase in tracheotomies. So it's important to see how to manage these patients, whether in a critical care unit or in a specialized unit for these patients outside the critical care. A protocol to wean patients approved by current evidence would be progressive disconnections from mechanical ventilation, from invasive mechanical ventilation to spontaneous breathing, with conditioning of the airway with oxygen, high flow oxygen therapy, so that you alternate until the patient can spend 24 hours continuously disconnected. Before decannulation, we will look for the need of secretion aspiration, the capacity to cough if there are swallowing difficulties, or if there's any airway obstruction. And rehabilitation has to be multimodal. And it is important to implement the ABCDF measures. And that was it. Thank you very much. Perfect. So now we have our next speaker by Dr. Federico Gordo. So hello, and thank you for this invitation to this very important event where I'm delighted to participate with colleagues from around the world. And the topic that I am in charge of is the topic that in ICUs we left alone, and it becomes more important, which is ICU intubation, to see where we are at currently. The history on this is that intubation in critical patients we knew is a complex process with regards to the clinical situation, and something very important that we don't have a lot of time on many occasions for a previous assessment. We know that this is worse in situations of hypoxemia, hemodynamic instability, perhaps low levels of awareness, and marked because of emergency to intubate. One of the first studies that expresses the importance of this in ICUs is a study in France, 67 hospitals with intubations in critical patients, not necessarily done in the ICU, where they described an incidence of heart problems in close to 3%, and they indicated risk factors that were independent with mortality or the appearance of attacks at the moment of intubation. And to reduce risks associated to intubation, we have described different elements that have the fundamental purpose of having a greater rate of intubations at the first attempt to be able to reduce the appearance of complications. Amongst those, we have techniques as the use of guide wires, probes, or different materials to make the airway patent, and the use of different video laryngoscope instruments. And in my opinion, the patient's position at the moment of intubation, how to make the induction and pre-oxygenation. However, there was no evidence available, and the 2022 guidelines done by the American Association of Anesthesiologists, American Society, look for mechanisms to improve intubation in the first attempt. They started to work looking for ways that allowed us to limit the number of intubations to try to improve prognosis. In this context, we did a study, the Ducros study, published in Critical Care. It's a national study done in Spain, where what we intended was to learn in our environment and in the real world in a prospective study, complications associated to intubation, to see what were the risk factors associated to the appearance of complications, analyze the impact of those complications in the prognosis, and see what factors were associated to success in intubation at the first attempt. So we designed a prospective multicentric trial endorsed by our scientific society, SEMICYUC. And we had an inclusion period of 6 months. That was not the same in every single unit, but at each center, they could choose those 6 months. This study started in 2019, and then we had COVID. So in this intubation study, we have patients with COVID, which was a special value. The study was registered, it passed the ethics committees at each center, and the inclusion criteria were adult patients, and we excluded all extubations that were done outside the ICU or intubations that were conducted in a heart attack. So we did intubations inside intensive care units. Multicentric study, 42 hospitals throughout Spain. And in the design, what we established as a main objective was the incidence of major complications, looking at major complications, hemodynamic instability, with the definition that you can see here. And these major complications were included when these occurred 30 minutes after intubation, severe hypoxemia, or the appearance of cardiorespiratory arrest, and then the appearance of minor complications and the relationship with the prognosis of the appearance of complications, and especially to see risk factors or factors associated to success in intubation during the first attempt. The sample was 1,907 patients. I don't have time to describe the entire study, but you can see that these are patients that normally go into an ICU. It was going to be in our country, but around the world, with a BMI of 27, a SOFA on the day of intubation of 6, and entrance to the ICU of a mean SOFA of 6, with an Apache 2 of 19 and a Macocha of 19%. 2 patients had a Macocha over 2, which predicted difficulty in intubation. Most of the design, most patients were the medical type. The majority, 45%, the reason for the ICU was respiratory insufficiency or failure. And 17%, 312 patients, were during the COVID pandemic. Overall mortality in the ICU was 35%, and hospital mortality 40%, similar to the one described in the majority of series of patients with mechanical ventilation intubated in the ICU in episodes of respiratory failure. So what we saw was a greater rate of complications, 40%, and the major complication that we detected was the appearance of hypotension associated to the procedure, 26% of cases. Hypoxemia, 20, cardiac arrest, more or less 2%, and only 1% death associated to the moment of intubation. Very important is that mortality in the ICU was superior, significantly superior, both in ICU or as in hospital, in those that had a major complication on intubation. So this speaks more in favor of improving our techniques to try to reduce the appearance of major complications, even though make them disappear like we do in zero infections is truly complicated. We did a multivariate analysis to see the risk factors associated to the appearance of major complications. And you can see how the two factors that were protective was that intubation were coma and low awareness or consciousness, and the use of muscle relaxants in the moment of the intubation. Whereas factors associated to risk of intubation or risk of complications were the appearance of hypoxemia, the presence of hypotension before the procedure, to have an elevated Macocha, an elevated SOFA. So factors that were associated with risk at intubation and risks that were previously known, we were able to establish, and I think this is especially important now we are speaking about intensive medicine, speaking of phenotypes. These are not phenotypes, but these are risk groups that are differential. With a TIDE analysis, it's a system to stratify risk groups. We see that potential complications of intubation, there are some groups in which they go down to 12% with regards to the appearance of complications, 73% when we speak of a population of COVID patients with a Macocha of over 2. Curiously, the risk factor that produced a higher incidence of complications at intubation was that the reason for intubation was not a low level of consciousness. In that case, the risk of complications goes up to 44%. And when we saw risk associated to mortality of these patients, we saw that the appearance of major complications was associated significantly to the appearance of these complications, especially with other risk factors associated to mortality in classical studies. You can see the rank curve, where we can see the difference between immortality or survival in patients that have major complications at the moment of intubation. And also, we did an analysis not only of complications, but also risk factors associated to non-intubation on the first attempt. And we had 70% intubations at the first attempt, almost 30% in those that were not achieved. And what we saw as protective factors or factors associated to intubation at the first attempt, and we believe that that is a very important finding, is that the use of video laryngoscope reduced by 50% the risk of failing at the first attempt of intubation. Risk factors associated to the need of more video laryngoscope or more laryngoscope is that the first attempt is done by a resident, the presence of content in the airway, a Cormac or Macocha that is elevated, and that the reason for intubation is acute respiratory failure. And you can see it here, the protective factor and non-intubation on the first attempt and the use of video laryngoscopy that is significant. In terms of the devices we use for intubation, that was very interesting here to see how in 88% of patients in our case, the mode of intubation to begin with was direct laryngoscopy. There were other ways of attempt, but only video laryngoscopy was used during the first attempt in 11% of patients. When we compare a result with the Intube trial done in parallel and that took different ICUs with a population of 1,992 patients, some difference in inclusion criteria, but you can see how patients were comparable and complications in our group were 40% versus 45% in the IntuPro. And it was interesting that in our group, there was a reduction from 2 to 3% in intubation, cardiac arrest. And there's an important difference in the appearance of major complications in terms of the fact that in the Intube, 42% of hemodynamic instability versus only 26% in our group. And something very interesting, because the drugs used during intubation were different. I don't have time to speak of this, but in our case, there was an important percentage of use of fentanyl in intubation and also midazolam, that we normally speak of these factors associated to hemodynamic instability that we do not see in the results of our study, and this is something that has to be studied. Another interesting thing is that in our case, we use very little or a very low percentage FROBA or stylet devices to intubate, and also the use of the capnography that in our case is only used in intubation in 10% of cases, a percentage that should come up. The use of video laryngoscopy was similar in the two studies. So in other words, what we have seen is that 40% of patients have major complications associated to intubation, and that this could be a risk factor for mortality. In intubation, the first attempt is associated to a reduction in major complications, and it's important to continue working around this topic, and that clearly we see that video laryngoscopy reduces the risk of non-intubation on the first attempt. We will have to see how this evolves in the following guidelines. In our unit, for example, we have changed practices. Now all patients are defined as a difficult airway at onset. We have different plans and we use video laryngoscopy in all patients. Different types of video laryngoscopies. We have a very recent meta-analysis that so far the role of video laryngoscopy was not clear, so they compared direct video laryngoscopy versus video laryngoscopy, and it's clearly associated in this meta-analysis with a reduction of the risk of non-intubation at the first attempt. But however, it doesn't establish differences in terms of mortality. Guidelines have appeared recently that are the SIM guidelines based on a Delphi analysis that looks at different points with regards to intubation. And this is very important, the definition of a physiologically difficult airway. And I think that this criteria has to be evolved. And to think that in critical patients, independent of where they are, any airway can be potentially difficult. And as such, it has to be treated. And it speaks of how to prepare the equipment, the team, the devices, and how to do the technique for intubation, how to do the procedure, and how to manage patients post-intubation. And this concept is very important. This is a summary of an excellent topic. All agree on this part. We all agree on the planning and considering physiologically difficult airways in any scenario, in any critical patient. And we need to have a scenario that is prepared to treat these patients. Where I'm not very clear is that we all agree on the definitions that we have in the guidelines. For example, they talk a lot about using a checklist, and I would ask to all those that are connected, do you use a checklist when you're intubating? And there are always two people to intubate a critical patient. We talk a lot about pre-oxygenation with the non-invasive ventilation for choice. In our case, it was only 21%, even though it is true that there's a high use of high flow as a pre-oxygenation system, and this conditions a change. But do we recommend non-invasive ventilation? We're speaking of sedation, how to sedate. What role does midazolam, propofol, or fentanyl have? Should we include them? Do patients have pain when they're intubated? Our work of SEMICYUC is a very important topic, and it's controversial. And especially the important question, have we substituted all laryngoscopy for video laryngoscopy? And do we have enough evidence to reduce it? Do we know that evidently it improves intubation at the first attempt? And the use of capnography is something that in our case we have to improve and use more to guarantee the maintenance of the airway. We have a lot to research. It's a very important field. We have to identify barriers and have education programs to improve results and to try to reduce major complications associated to intubation that will not reach zero, but having plans, this clearly, I think, can be improved. I think that we have good data. I think we have data to improve, and this is the path forward to analyze our clinical practice to be able to improve the process with all patients. Thank you very much for your attention.
Hello, everyone. How are you? So first of all, thank you so much for having me. Thank you for inviting me to participate in this extraordinary scientific event. I was just looking at the schedule, and it's wonderfully organized. I want to congratulate the organizers. So we will start with recent advances in ECMO. will be done in Spanish. And I would take this opportunity to congratulate everybody, all the early birds here, and everybody who's probably at the other side of the Atlantic. Well, without further ado, let's continue. I assume that my presentation is well presented. My disclosures are really not really important for the topics to be discussed right now. So Gonzalo was saying that we're now looking at updates in ECMO. So obviously in this context, it will be for respiratory purposes. And truly in the past few years, we've seen a series of very interesting publications that have made a huge difference in critical patient assistance, especially cardiovascular patients. And when it comes to cardiogenic shock, ECMO, and other entities. But of course, there are also respiratory updates. And again, update is a bit of a non-specific term. When you say update, you think of, okay, I'm going to go into PubMed 2024 and look at all the new publications and then try to do some critical analysis. But I think that's not really what an update should look like. So this is what I would propose. First of all, we're going to try to establish a baseline, right? To have a very solid foundation to start talking about the updates. I've only have two slides for that. And then we're going to go and look at this step by step in greater or smaller detail, following the importance of the existential and scientific environments. And more than anything, in the more particular aspect of ECMO assistance, meaning for patients with respiratory dysfunctions or ARDS. I have a couple slides in the end to speak very quickly about that. If there is a real future for this environment in ECMO, in distress and in respiratory insufficiency. So what's the baseline situation? So I presume that most of us understand that, all right, let's go. Everybody understand the basis, so let's go straight to the evidence. All right, so we should always include a rationale, and we will be looking at this during the presentation as well. So what does the evidence? We have two recent RCTs, recent, and in between quotation marks, meaning that it was from 2019 in Lancet, the CSAR study, 2018 New England, the OLIA study. Both of those trials issued these two recent recommendations from the European Society for Intensive Care. So in the end, I'm going to try to remove my camera so that we can start looking at this. And so we would have to start right now. I'm not going to go into ECOR, just a little pearl. So here we have the SEMICYUC recommended guidelines. This could be a topic for discussion if there's time enough. But in the end, we have ECMO in 2023. ECMO is recommended for severe distress patients with cutoff points used. And we include indications from the earlier. We have two rationales for oxygenations. And after 680 after 3 hours, and a third case, which we'll discuss later, related to respiratory acidosis. Beware of this. This is recommended for stress that is not related to COVID, distress not related to COVID with lower evidence in order to be related to COVID pathology. This is the baseline. This is what we know at a scientific level. It's pretty solid. So in spite of the fact that ECMO indications is based on blood gas analysis data, we see that effectively the machine is quite effective. The blood that comes in with a pressure of 500 is very effective in terms of gas exchange, but it's not that saturation increases, no. But the point is that the system allows to reduce the aggression of mechanical ventilation, to reduce that additional injury, whether it's sepsis, pneumonia. And you see here that mechanical ventilation is not related to ERDS. The lower ratio of mortality actually decreases. You see, with ECMO, you can take this all the way to infinity if necessary. And in fact, and for patients who are benefiting from ECMO, we use ECMO for this basic reason. So this is the baseline with which we start operating. So starting with this concept, and if you ask me, aside from the impact of the mechanical ventilator in stress patients with ECMO, There is also another very clear benefit in my estimation, and that is that it allows for the following, what you see on screen. That ECMO allows, and we'll go into further detail, but ECMO allows you to awaken the patient to, well, of course, muscle relaxation is a whole entire topic, but you can get the patient to be awake regardless of whether the respiratory pathology is resolved or not. Here you look at several patient videos where there's lung injury, lung affection, but the compensation of this increase of the oxygen consumption will be compensated with ECMO. And this is absolutely impossible without this extracorporeal assistance. And I think that this has a great relevance for patients. In fact, nursing staff knows that very well. When they start doing this, they'll have desaturate, they'll have tachycardia, they'll become hypertensive, but it has an overall impact, delayed impact, that is, in the recovery of their quality of life. And I think that this is a message that is worth sharing with you. We're intensive care physicians. We specialize in critical patients. We work in the acute phase of the disease, but our objective should not be increasing oxygenation. The objective is that these patients recover their functional status. This is why I think this is so important. This is why ECMO assistance is so important. See, we typically don't do x-rays on deceased patients. This patient is alive. She was alive at the time of the x-ray. And look at the degree of aggression within the lung. Notice that the airway hasn't been instrumentalized, and she's assisted by ECMO. And not only do I also like to show videos as well, so not just images. But notice that I can't list off every single benefit, and they go all the way from preventing and avoiding sedation effects in terms of delirium and the like, and prevent undesirable effects from mechanical ventilation. Surely, when we discuss ventilator-associated pneumonia, will be discussed. But you understand that you can remove intubation from patients receiving ECMO. And there's also other elements that are underrated. When you awaken the patient in a situation where you still have a lung inflammation, you can awaken them, allowing this respiratory extracorporeal assistance. And in this way, you can have your anamnesis back as a diagnostic tool. This is not something I mentioned in literature, but at a practical level, I think represents a huge benefit for the patients. Unfortunately, I can't go into too much detail. So we would have to say that that is a major update in respiratory patients, especially chronic ones, because hemodynamics typically take 5 days existence, but respiratory patients typically take 12 to 14 days plus COVID. It needs as much as 17 days. You can awake them via extubation or via tracheo. You can do, it is possible, positive in the end for these patients, but of course, many of you might be thinking, well, it is likely that there is some undesirable effects. However, the increased oxygen consumption will increase. You can compensate that with ECMO, and the consumption of resources is so much higher. You'll see that there's plenty of professionals surrounding the patients, and they will not need that same degree of intensity regarding staff requirements. Ethically speaking, it is conflictive. I say that because we've had cases in which there's patients awake, but venous ECMO with a reversible lung pathology who are not good candidates for a lung transplant, and we've had to communicate with them doing some intra-ICU life, and we had to disconnect them because they did not have a good prognosis. And of course, that's a difficult ethical consideration. This is quite stressful for the team. And finally, we have other effects, or rather, there's a dark side to this proposal. One of them, which I think is quite relevant in this scientific context, is the risk of exacerbating lung inflammation for causing energetic ventilation of these patients. And in order to speak of these updates, this is a reason for study in several environments, and especially in animal laboratories. The ability to control the Herrenbrunner reflex which is present in breathing patients in spite of normalizing blood gas. And that is caused by the lung inflammation. And we believe that in the end, this is a net negative for the patient. This is one of the most important investigation foci in ECMO in respiratory assistance. In the clinical environment, there are several proposals for resolution. So this is evidence from 2017. In this population, there is no ECMO. And in fact, we see that they're using spontaneous modalities. In this case, they're using rocuronium, and what you see is that spontaneous ventilation remains, but this excessive respiratory distress and effort is reduced. This partial neuromuscular blockage had already been defined in the 1980s. It's a very interesting publication. I can't go into detail because I don't have enough time. But in this case, it is in healthy volunteers. Many of you will say, okay, so this is this that Dr. Riera is saying. How good is the evidence? Well, the evidence is not good. It's weak. The rationale is very good, but the evidence is not. And with this purpose of developing evidence, we developed the MHOTEP study for COVID patients during the first half of the pandemic. We did everything that we could, and we didn't awaken patients as much. And you'll see this is the control group. So I will be explaining the practice in a moment. And you'll see that they had a positive effect in 30% of patients. In the second half, it was right under 90%. And we established a rest and look protocol. And this is just a reference point because I think it's what we apply at our centers because this is what we were able to interpret from evidence and experience. But we understand that there has to be a starting resting lung period in which we have to prevent the increase in lung pressure due to the negativization of pleural pressure, the use of esophageal balloons, virus tags, microbiology labs, etc., and then removing the tracheostomy. And in our case, we did early tracheostomies very often and try to do that. So here we can go into the first part of the pandemic, and the profile is not the same as in the same situation. But yes, the P was not significant. And so to summarize, COVID, distress, and ECMO for very serious patients, they'll have a good effect in as many as 75% of the patients in those who received these protocol. And this is the most important part. After 6 months, only 20% of this group was actually in rehabilitation centers. And the effective control is 60% with a significant p-value. Therefore, the awake strategy, in our case, combined with an initial lung resting period, in our estimation, and this is demonstrated, and you could say that it is a positive in the long term for all patients. So with this ambition to generate evidence in the awake trial, in the awake protocol, this was a multi-center study developed by our group in the White Journal, when we saw a series of COVID patients that required our ECMO for more than 30 days. Well, in this case, the awake situation was associated to a lower mortality ratio. I can't go into details because we don't have time, but certainly it's an update. And it's also good news that the focus in the respiratory ECMO environment will go from survival into functional and quality of life 3, 6, and 12 months after intervention. And I think this is especially important. You know this study very well. When the ICU train goes above the patient, the functional impact is very important. So this is here we focus on a COVID populations where we have a PAFI of 26. And so we have an alteration of functional status that is very important. But at 2 months, notice that 65% of the population would return to work, 62%. 2 of them actually became pregnant during those months. 2 pregnancies after having this terrible PAFI. So that's an amazing recovery after that intervention. And for conclusions, again, I can't go into detail, but they state that indeed it is specifically related to this functional recovery. And so here we have in the ICU, please notice, and surely we'll have more publications. I don't have time to go into them, but again, ECMO looks great, survival looks great, but what happens to these patients in the end? Well, it turns out that in 2023, well, I became a very staunch defender of the protocol from 2023. When I see a venous ECMO protocols, when I see 60% effectiveness, I think this is completely wrong and it's completely outside of the guidelines. When it's prono pre-ECMO, it has to be 100%. 60% is not good enough. So in my estimation, I can tell you that we have made it. We managed to do lung transplants, recent lung transplants with DPI. Now, with the use of an ECMO, okay, so in my estimation, it has no real rationale. We don't expect to have great results or great terms. And now we have evidence that this trial that I'm sharing with you from December of 2023 was negative. You'll see that in Lisbon, they developed one that, and the research group in this study were both in the pros and cons. You'll notice that at the end of the year, they stated that the evidence showed that proning the patient in the ECMO protocol actually was not beneficial. You could say that it is a COVID-only population, but again, looking at the rationale, looking at my own criteria, I mean, we had evidence that stated that it wasn't essential. And maybe in one particular patient, sure, we could try it. Again, you never take extreme measures in medicine. That's not a good strategy. So those are the updates for pronation and ECMO. You have no evidence to back that up. A lot of people will defend proning, saying that, well, we'll still help the right ventricular function. So I would have to say that specifically the dysfunction from the right ventricle for ECMO patients, I can then focus on this for more time. And prolonged ECMO, in my estimation, is overrated. In our experience, it probably has to do with how we do patients, because we're awakened, how we do things, because we're awakened patients. The dysfunction of the right ventricle in endovenous ECMO perhaps has been observed to be effective in many cases, but well, it is described anyway, and I wanted to share that with you. So it is likely that, well, now we look at the study, the Intensive Care Medicine Journal from 2024 from the ProMed study. In the end, now it's back, the Delphi is back in swing, I suppose. So we have a conclusion, and one of the conclusions here is that they propose a definition for right ventricular dysfunction in ECMO patients with distress, but this definition has to be validated. So I think there's a certain degree of uncertainty, but here there's content that applies to distressed patients with venous ECMO and technology developments as well. But only one of them is related with this environment, with this specific cannula. You'll notice in the X-ray that they follow the Swan-Ganz catheter. It will drain the right atrium. It will drain back into the atrium. And again, if there's a competent pulmonary valve, then it will be effective. And it supports the right ventricle, sure. But from an instrument standpoint, and again, we see that these right ventricles are heavily affected, it becomes more invasive. And for those patients that need more support, the thickness of the cannula will not allow me to give a lot to increase the flow. But again, the increased cannula is considered to be protective. The other strategy is using draining cannulae to return oxygenated blood into the lung. The most relevant clinical experience is this one, of course. However, the Chicago group with 40 COVID patients shows an extraordinary survival, just right under our survival, combining protecnol and early extubation. We don't do this. We don't do this at our center. So during the first days, we considered that the lung should be allowed to rest. And one of my brilliant colleagues directly extubate and attempted to reduce the distress and do early rehabilitation with a very high survival, just under ours. So technology developments, focusing especially in miniatures to do a smaller system and to make it more biocompatible. This publication from Christian Hernández, who was obsessed with the format of the pumps. I will not go into detail. And then the oxygenators. I mean, this is relevant to the future. I mean, Here we have oxygenators that are millimetric in dimensions. And here I'll leave you this other pearl that will continue to develop in this environment, but also in the artificial placenta, now with animals. So I am almost done. I'm almost done, I promise. Expansions and updates in ECMO. So we know that the indication is expanding. And again, expanding is a bit of an aggressive term. I mean, either we find populations that are beneficial because it used to be a counterindication. For example, this one in 2023 in the respiratory medicine. So the transplant of hematopoietic components is a counterindication for ECMO. And now it's the first statement. It should not be considered a counterindication. Now, I don't have much time to go into detail, but I do have to say that I want to show this because the most important indication is distress associated to CVD. It is associated to good results, especially in miliary tuberculosis and ECMO-assisted patients with very good results. I mean, the typologies and the list of pathologies that work as an indication, it keeps expanding. This is another interesting study analyzing anticoagulation and thrombosis. Thrombosis, the more common we have thrombosis, the worse the bleeding is. So of course that makes sense, and of course it will have an impact on overall survival. And anticoagulation shows a trend that negates any gold standard, and any of the oral anticoagulants show no real difference. So I would like to just mention thrombin inhibitors as the best option. And nosocomial infections, a lot of publications, a lot of interest from ECMO to infection or from an infection to ECMO. Here we have clinical infectious disease, a review, a combination of ECMO medications, and in the end, we have no standard definition for nosocomial infection in ECMOs. Point being is that the infection signs are identified in critical patients. It is very difficult to identify nosocomial infection. Another related publication, and I'd like to show this one, the ECMO Central. And now we're finding effective definitions in adult patients. Among them, the definitions of infectious processes. Another proposal proposed this year. And look at this, and this, you can see the growing expansion in ECMO from the International Society for Lung Transplantation proposing other definitions. There are active projects for ELFI, the Delphi project, and the mechanical ventilation associated with ECMO. So I would like to mention two of the studies that we're developing in this multicentric ECMO studies. And keep in mind that endovenous ECMO, because of the fact that endovenous ECMO takes longer, it will have those considerations. This will make a difference in incidence. It will have a difference in the rates. And our center, we're going to much more detail. We're trying to go all the circuits, all the cannula, and trying to log all the clinical parameters related with positivity. And finally, nosocomial infections. This is just one publication from 2024 showing that nosocomial infections in ECMO patients will increase mortality at the hospital in 37%. And this also has an impact on the nosocomial infection. It's very difficult in ECMO patients because the system will alter the TKPD. So it limits the antimicrobials that we can use. This is summarized in this review because we collaborated with them as well in 2024. And finally, 2 slides on the future, very quickly. So the impact of endovenous ECMO is to do something about the aggressiveness of ECMO treatment. And this is independently of the PAFI. So, as we were saying, this is a future consideration. You have to try it out in well-designed studies, etc. And we are absolutely suggesting that ECMO should be indicated. And it's a point of development. And I would just like to say this as the most important message. We already have, I'm not going to see solid evidence, but we do have evidence from Aeolia. The third indication group is related to mechanical ventilation deficit without very low PAFIs. So maybe it would point towards this cohort, but if you go to the supplemental and evidence, as very often happens, you'll find some very interesting information. So notice that in this specific population, so here we have a brutal impact here. It will dramatically decrease mortality in this population in which distress, AFI isn't doing that poorly, respiratory acidosis, and always intravenous ECMO, survival is much better compared to the control group. Last slide, I promise. The future, home ECMO. I've told you about one case, and the saddest case, I think, I will just have to say that we have had patients awaken from the machine saying, we have no solution for your lungs. We're going to have to disconnect you. And that's Robert Parlett's obsession, or the person we look up to take ECMO home, to make a miniature ECMO, improve systems so that you can use it as a burning heart. There are some studies in animals. There's a very particular patient, and they're still in experimental phase. And definitely, the perspective is as obvious as exciting. That's all for me. Thank you.
Thank you so much for your excellent presentation. We are a little bit over time. We have a couple of minutes. There was a question in the chat about anesthesia induction and ketamine. Can you comment something about this? Well, during induction, this is very controversial. The Spanish group, not only ketamine, but the use of sedation and analgesia associated during intubation. That's a controversy with other groups. It's very interesting. In the case of ketamine, it is clearly indicated and it's seen in the guidelines. And it's an additional measure to decrease complications, mainly hypotension, like Dr. Belalcázar has said. And we've used it for a long time. We've used ketamine for long, and we've used it forever. And maybe there are going to be changes in the future, but we're going to see which agents are the best. But ketamine is, of course, indicated. Thank you so much. Okay, I wanted to tell Dr. Margarita Marquez, can you speak a little bit about what you were speaking about, the indications that are more useful for the chronic critical ill patient? I don't know if you're listening to me okay? Yeah, we are. Well, this is very interesting to prevent infections and pneumonia. And maybe it can substitute the manual aspiration of the nurses. Jordi, thank you so much for your talk. About the awake ECMO, I believe it's one of the most interesting developments for those hospitals with a very low volume. What are the best patients to try to do awake ECMO in distress? Could you do some recommendation with low volume centers? Thank you for your question so much. Sorry, the audio is a little bit off. So we have to guarantee the patient's safety. We need 4 or 5 people around the patients. If you cannot guarantee this kind of support, well, my recommendation is not to wake ECMO. And in the initial phase, if you don't have enough experience in your center, I would be very conservatory. I would be cautious and I would wait for the disinflammation of the lung. So we have to analyze each patient and have a clear image in the X-ray. This has to be done only in highly trained centers and experts in ECMO and in high volume centers. I believe that the patients can really benefit from an awake strategy. I would prioritize the resources in high volume centers only. Okay, we have to finish this session. I would like to invite the audience to stay connected. We're going to have a distress discussion. Thank you so much, doctors. Very interesting topics. Thank you. Thank you.